And what is your name?
Sam.
Okay, Sam, and what is the problem with your shoulder, and which shoulder? Not the one that shot up.
It's my left shoulder. It's really weird. Like, I know the pecs are really tight, but I have pretty good mobility up until I do this movement. And then I start feeling all of this, like, pressure and tightness from the pec to, like, the back of my shoulder. So I don't know what's going on.
You guys think you can help? Okay, so our presenters have already done rock, paper, scissors, and it looks like Carrie's going to be the first person to get to assess you and show you some treatment intervention for your shoulder. Carrie, come on up.
Come on over here for a minute. So I just want to have a starting place. You always go to the unaffected side. Let it go. So right away I can feel tension there. So I know sort of what we're dealing with. All right, have a seat here for a second. So, as practitioners, we all are faced with the same three questions. Somebody comes in with a shoulder dysfunction, and our questions are, where do we treat? Right? You'd say, well, obviously you're going to treat the shoulder. Right? But there could be other things. That's what we're going to be exploring. And then once you figure out sort of where you're going to treat, the next question we all face is, what are we going to treat? Because there's a lot of anatomy here, right? There's skin, there's superficial fascia, there's deep fascia, there's capsule, there's muscles, joints, all sorts of things. Now, the shoulder is really interesting because when somebody comes in with a shoulder dysfunction, you notice I just evaluated the shoulder. We only have about 8 minutes each. But I would be checking her neck because there's connections from the neck to the shoulder. I would be checking her thoracic spine because of the connections of the shoulder to the thoracic spine. And what about the front? Right? The pec major, pec minor, so the ribs and the sternum. And if you look at lat dorsi goes all the way down to the lower 6 ribs, the lumbar spine, and then it continues fascially all the way down to the feet. Okay? Let's have you lie back. A question that we need to ask is, how does a body heal, or how does the shoulder heal? Well, it's going to heal by blood supply coming from the heart, the subclavian artery, to the axillary artery, to this area, carrying oxygen and nutrition. So there is a pathway. Now, in order for that shoulder to receive that, you got to get rid of the toxicity. So there is venous drainage and there's lymphatic drainage. Okay? So as a practitioner, we have to decide, do we treat the shoulder or do we treat the pathway? And we talked about how all these different areas can affect them. I'm just going to just check her legs real quick. And I can feel tension here. And look at this leg. This leg moves really well. This leg is very restricted. There's something happening here. So one thing I can do is I can come over here and I can feel her shoulder, and right there's a barrier. If I bend this knee and I come over here, all of a sudden this shoulder is released because of the fascial connections. So you might be thinking, well, why would you treat this? Because there is a fascial connection. I had a baseball player played for the Florida Gators, and he was treated all summer, but they all treated locally. They treated his muscles, he had massage, they did mobilizations, but they just treated the shoulder. And actually most of the problem was coming from below in his legs. So a lot of times I evaluate for a systemic approach first, because I want to make sure, think of, if it was a problem with her head and neck, think of it as a penthouse of a building. So this is starting to release. There we go. She feels something in her hip here. I'm going to come over here. Now, so now I'll come over here. Shoulder moves much easier. When I was at osteopathic school, they'd always tell us, wherever the patient complains of, don't start there. Work your way towards that area. Now, remember, there's a pathway here. Can I put my hands here? I'm just going to evaluate our clavicles. You can see the right clavicle moves very nicely. Look at the left one, it's restricted. I'm just going to check ribs 1 and 2. Right ones move, left ones are restricted. So there is restriction here. Move your arms out a bit. I'm just going to check the pectorals. I'm going to feel here. And this is much more restricted. So these are going to affect flow. So what I'm going to do is I'm going to open up the pathway. And then my friends over here are going to come in and work very much locally to help her out. So I'm going to come in here. I have a sensory hand and I have a motor hand. And I feel a line of tension between both areas. This is called a long lever technique. Do a nice little pump, opening up this clavicle. Because remember, structure affects function. What's underneath the clavicle? The arteries, veins, lymphatics, but also the brachial plexus, the nerves, but there's also energy flow as well. And come in over here. I can do an internal rotation. Again, this is my sensory hand. Feeling all the way along this clavicle. Good. So I want to come up over here. My hand okay? So I'm going to work her ribs. Now, why do I want to work the ribs? There's something called Boyle's Law. And Boyle's Law means if you can increase the volume, the pressure decreases. So why do I want that? Because any type of venous drainage, lymphatic drainage moves from a high pressure to a low pressure. So you want to have increased, right, cavity movement, the thoracic cavity. So my left hand is sensory. My right hand is motor. I'm working. When you do this, if you do this there, what happens? You're lifting the rib. I'm mobilizing the ribs. My whole focus is to improve that pathway that we just talked about. I can also come in laterally, opening up the ribs. Go. And then I'm going to use the lever this way. And again, open up this clavicle. The clavicle and ribs 1 and 2 are extremely important. And my left hand is sensory. It's also a little bit motor. Go. I'll come over here. So you can see this moves easier. Clavicle moves easier. Ribs 1 and 2. I'm going to feel any fascial lines of tension. So because of the continuation of fascia, as I come in here and I lean back in traction, this is pulling up into the cranium. And as I work my way along, I'm into her chest. I can feel some tightness here. And I'll work around. And again, I stay within her comfort zone. Breathe in. And out. Breathe in. And I'll just come in here, just make sure this is open. I'll just gently work any type of muscle fascial connection from the head and neck into that clavicular area. Breathe in. That's breathe in. Good. Relax. So this move is much easier. So I like to work very systemically at the beginning, and I do that to make sure the pathway of healing is intact. And then I do local work. Then I'm going to check the muscles, bones, joints, etc. So my partners here will come in and they'll finish things off. It's a pleasure meeting you.
If I can, actually, Sam, I'll have you sit up if that's all right. So a couple of key things right here. Excellent demos already through this process where you're looking at a more systemic approach, which I think all of us need to do if you're going to give a better treatment for your clients or patients, okay? Walk them through their full range of motion, whatever else it is. And in fact, I'm going to get the entire audience to do this with us as well, okay? So I want you all just to follow the actions that I do. Let's do it together, and you'll see your shoulders feel better, even if you just do basic functional stuff like this. So, Sam, if we can, we're going to put our little butterfly fingers up like this with a smile, okay? And let those butterflies fly up to the top into full abduction, all the way up. And while we're doing this, we're watching movement, of course, and then all the way back down, fully across the front like that. In fact, we should get a picture of this. Everybody with their arms up. If we can do that, that would be a good picture right there. Okay? You're not fast enough. Okay, we gotta wait. Okay? Anybody who's seen any research out of Harvard, this is a power pose right here. It actually improves mood, lowers cholesterol, cortisol levels, all that. I don't think it would do cholesterol, but all right. Okay, so we're back down. How are you feeling? Yeah, a little bit of tightness right at the front. Okay, excellent. Okay, next thing I'm going to have you do is bring your arms all the way up to the front and say, it's good, like you're a referee, a football game. It's good, okay? All right, and then all the way back. Extending your shoulder back, just looking how you move. Excellent, all right? And then last movement is going to be, depends on the client, how they are, but usually I would start like this and say, can you turn your arms all the way out for external rotation? And all the way in for internal rotation. And if it's there, hands behind your back, bring them off your back as well. How do you feel there? Pretty tight, but wasn't irritating or anything, right? Okay, excellent. And then I'll do one more movement because that's clear. I'll do one more up here like this. Full external for a scarecrow. How do you feel there? Yeah, exactly. This is just to get baseline of function and warm up your tissue a little bit. Okay. What did you just do right there? That was just simple active range of motion. But what did you really do right there physiologically for that person? No answers? Ideas? Somebody wants to say something? Okay. Synovial fluid got moved around there. What else? Excellent answer. Okay. You also stimulated local nerves in the area. You increased blood flow deeper in the tissue. You let her move in a safer space to see baseline of function is okay. But we're going to do better than that on this sweet card table. Just wait, I got to lower it a little bit. And I'll have you scooch to this edge for me, Miss Samantha, if I can. Yep, just something like this. Okay. So, one of the biggest things for me is I work with a lot of pro athletes and I treat a lot of therapists myself. And I've been doing it for over 20 years, and I get aching in my thumbs right here from the constant pressure and pushing in like this. Same thing for my fingers. If I ask the group out here, what are the weight-bearing joints of your body? What would you tell me? What are the weight-bearing joints of your body? Hips, knees. Yeah, but you didn't hear what I said. Super therapists. What are the weight-bearing joints of your body? These little things right here are not designed to carry weight, yet we're loading them up heavy every day with all of our treatments. So if you can find a way to take the load off of these smaller joints, you're going to last longer in practice. So one of the things that I have here is this is literally the shape of my thumb right there. Okay, this is literally the shape of my knuckle right there, so I can use that to generate a little bit more force. So one of the things I want to do is we're going to take you through a little bit of pin and stretch type movements, or active release, some people will call it, whatever else it is. If anything's too much at any time, please let me know right away and we'll modify what we're doing. All right? I do want to just do a little bit of palpation first, just to check a few things. Do you actually have a diagnosis or not? Okay, just wait a second. Mark, how much time do I have? Like 3 minutes, 5 minutes? 5 minutes, perfect. Okay, if you want a really quick way to assess if it's rotator cuff, I'll do this for you literally in 30 seconds. Hold your hands like this. I'm going to try and push your arms apart. Don't let me push. How does that feel? No pain or discomfort? What muscles did I just check of the rotator cuff right there? That's going to be subscapularis. You're going to catch a little bit of pectoralis major, maybe a little bit of latissimus dorsi that pulled things in like that. So that's a quick check. Those are negative, probably not your pain generators, okay? Right here, you're going to hold your arms like this. I'm going to try and push you in. Don't let me push you out. Don't let the man push you in. Hold strong, Sam. Hold strong, Sam. How does that feel? Yeah, I would give this a 4 out of 5 muscle test on this side. A little bit of resistance issue right there, but was it painful? And are you right-handed? You're left-handed? Okay, so that is a surprise, and that is a good finding now because you're left-handed. So that makes me think more of what muscle group? Infraspinatus? Teres minor is what you're going to be thinking of right there. Even though you said it feels tight in the front, right? We'll be doing a combination of both those things in a little bit. And then, what else do we have to check for rotator cuff? We're just going to have your arms up to the side like this. Hold them up. Same other thing on the other side. Holding up in this position. Don't let me push you down. Hold strong for 5, 4. How are you doing? Hold strong, 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 strong. 3, 2, 1, and relax. And how did that feel? That was Big Owl. Okay? In our investigative process, what do we think Big Owl means? Supraspinatus, right? Of course, there's going to be middle fibers of the deltoid that are also involved with that, but mainly supraspinatus. All right, so for a quick demo, I'm going to do some pin and stretch type movements with this. Usually what we would do typically, you wouldn't have an instrument with you. You take your thumb and you'd find the spine of the scapula, work your way up a little bit superior, anchor into there. I am physically limited by the size of my hands and how much force I can generate, or do this reinforced thumb contact that I know we all do. Okay, well, we're taught not to do it, but everybody does it. But I could really do it like this. So I'm going to use this edge of the thumb. If it's too much, again, let me know. And I'm going to push in like this. Can everybody grasp how much more pressure I can generate by using this part of this instrument right here? Okay, we're talking like 10 times the pressure. And one of the key things I say, I'll be doing a demo later today for instrument-assisted techniques, or tomorrow, pardon me, is that your first treatment has to be light. Everybody say it with me. First treatment has to be light. It's going to feel like you're doing next to nothing, and the person's on the table ready to tap out. If you want to have YouTube videos up on this stuff too, where you can see it. So I'm just going to start with some light palpation. So I found the spine of her scapula. We're just going to sink in and start to work through there. How are you doing? Not too much pressure? Are you sure? It's fine, okay? All right, so I'm going to sink in a little bit deeper. Okay, I'm just going to work my way down. So we're going to hit over top of the acromion. I'm going to go a little bit lighter. You can feel me dropping under the acromion, right here a little bit deeper, and then sinking in. How's that for pressure? You sure? Okay, I'm just trying to read your nervous system here a little bit. Describe what it feels like, actually. So, yeah, it feels like I'm really digging in there. The nice treatment that we saw at the very start, that was a nice, easy work through the entire system, was good to start. Now we're really going to get into it. You're going to hold this arm up here. I'm going to pin in, and then you're going to move your arm down and across your body this way. So everybody can see this is a shortened position for supraspinatus. We're going to anchor in, and then you're going to go ahead and move all the way through. How does that feel? Yeah, it's not too much, right? Because these can be... Yeah. I know, so yeah, exactly. But don't feel like you have to take a ton of pressure. Depending on your size and the patient's size, sometimes you can actually anchor in, and I can roll through and control your arm. But you can feel how we can feel the fibers actually sliding and moving through the instrument all the way through here like this, right? Everything is okay there? Okay, we're going to do another movement. This time you're going to have your arm to your side, because we had a little bit of infraspinatus and teres minor there, so you're going to turn in like this, okay? We do more aggressive protocols, but just for a quick demo here, how are you doing there? Okay, work your way through. Good. And can everybody appreciate biomechanically how easy this is for me? Like, this is mega thumb pressure, especially for bigger, stronger people. You anchor in, they move. Are you sure that's okay? Okay. It's movement. Really good. And the subtlety of what I'm actually doing here is, as she's moving, I'm actually grabbing the tissue a little bit and then stretching out a little bit more to give a way deeper stretch than I can get myself. Okay. And everything's okay there? All right, perfect. Let's go ahead. We'll get you laying flat on your back, and we'll do a quick few shoulder mobilizations here, and we'll call that a quick treatment for our next person. Okay. So a couple of movements right here. If you want to have good control of your person, how many of us do Brazilian Jiu-Jitsu on a regular basis? Can't believe we've gone a few minutes without that. Okay, if you want good control of somebody's arm, Your best control is actually going to be underneath the elbow like this, and her hand is beside my body like that, and her forearm is resting on my forearm, and you can take from here, and we can spin in and actually decompress the shoulder substantially with this movement, and it winds up being a movement from my hips that allows that to happen, okay? How's that for pressure? Yeah, some popping and clicking. Oh no, is that in scope? Can I do that? Okay, was there a high velocity thrust there? There was no high velocity thrust, so everything is fine. And all I'm doing is just light challenges to begin with. If I'm really going to get into a shoulder well, I'm actually going to take you into full external rotation, still with that same support. Realize this would be contraindicated if you had instability of your shoulder, because this is a loose, very loose packed position right here. But we can go from here, traction, and then mobilize. Here, traction, and mobilize, and kind of go through. And I'm trying to watch her the entire time to gauge for areas of potential pain or discomfort. How are you doing? Okay. And can everybody see the ease of this movement where her arm is actually resting on my leg? And we can kind of pull through here. So as you get into, well, who's our biggest football player right now? Dave. I've got one player who is 6'7", 367 pounds. Okay. So he is literally two of me, and his arms are like the size of my thighs, basically, right? So you want to have good mechanics, good control. This one will be a little bit more limited because we're internally rotated. But can everybody see how I've got multiple areas of support? She feels well controlled. How are we doing? Yep, so this will be part of the neurologic involvement, and that'll be an assessment for another one. I'm just focusing on the joint for right now, but yeah, that's good. Okay. And then back to neutral, and basically a little bit of traction out, going down, traction out, going down, and then I'll probably be passing this off to another fantastic practitioner who's going to take you through a little bit more of this. So a couple of the wins from this treatment: number one, saving my own hands by using instruments; number two, checking in for your overall range of motion for your own nervous system; number three, identifying a little bit of tingling that we can work on later as potentially brachial plexus, scalene compression, and all of that. And number four was the treatment before this that was excellent. That was a systemic full body approach. Okay, good stuff or super good stuff? All right, okay, thank you very much. Okay.
So a lot of what my colleagues did were a little loud, but first thing I do is check sternal clavicular scapular function. So if you're abducting and your clavicle's not intergliding and lifting with the scapula, you have shoulder impingement. So I'm going to have you just stand up for a second, please. And the left shoulder, the right shoulder, basically soft and feel no impingement. Now, I do want to give credit to my colleagues because Carrie's already looked at sternal clavicular scapular function, first rib, second rib. I always do that first before any soft tissue care. But when I go here, this side, she's guarded. Right now, something's pushing back at me. So I find that if I have a model, I can teach the client what's impingement. The brain science San Diego research says if we can change the brain, we can change the pain. So basically, I'll show you what I found. There's a narrowed space between your acromion and your supraspinatus and the long head of your bicipital tendon. So if we don't get the humeral head to drop, we're not going to be able to treat the impingement. The other thing is I really like that Nick tested the rotator cuff muscles for strain. So we do active range of motion. This was a passive assessment. The muscle testing is, but I'm finding that a lot of people have bicipital tendinosis, short or long head. A lot of people have pec minor, and they're told it's a rotator cuff injury. So I'm going to add just two more tests to the brilliant testing that my colleagues already did. Normally I would do the rotator cuff, but Nick did that. So if I look at the biceps, flex the shoulder, palm up, I'm looking for pain at the coracoid process, anything when I push down. So you don't have that would be real painful right there. If I look at pec minor, take your elbow towards that hip. Is there any pain in this spot right there when we muscle test? So we really simply have an impingement. I was teaching a Zoom course in Australia, and David Sheehan said, if you only had 3 minutes, I've got 8, I've got 3 left at least, what would you do to treat 80% of shoulder problems? And that's what I'm going to demonstrate here. So what I'm going to do, two things. I'm going to balance out your rotator cuff injuries. Now look at her palms of her hand. She's internally rotated. Can you treat trigger points in the infraspinatus and teres minor when they're rotated forward? No, it's impossible. They're locked long. So typically pec minor goes short, Posterior rotator cuff goes long, subscap gets short, lack of what fluid? Synovial fluid, hyaluronic acid in the shoulder joint. So I have a technique that'll treat all of that. I'm going to have you go face down, please. And basically, think about pec minor, ribs 3, 4, 5, 6, 7, coracoid process. Pretty much everybody has a short driving cars, working on computers. So first I'm going to stretch your pec minor. My finger pads are right under the belly of the pec minor, pulling the scapula up towards the rib cage. Then I'm going to relax the capsule to make the brain feel safe. Just gentle compression to relax the shoulder capsule. Stretch the capsule, relax the capsule. Can we actually, for the reason of the viewers, can we turn your body, can we bring your head down this way? Since we don't have a face cradle in there anyway. You're welcome. When I just face down this way, when I teach, I use 2 screens. Tomorrow morning and Sunday morning, I'll have 2 screens. The camera will be on my hands 24/7. PowerPoints will be on the other screen because my daughter, with her dyslexia and her autism, needs to see a picture of every technique. So you'll see a picture of every technique. You'll see every technique will have a photograph, and the patient will have a picture painted in their brain so they can respond to my therapy. So pec minor, gentle lift. She's very guarded, so I'm going to relax the capsule and stretch the capsule a little bit. Now the most important thing, and I want you to see this picture right here? I'm going to create space between your acromion and your humeral head. So I'm showing her what I'm going to do. I'm going to create space in there. My favorite thing is to make a lever here, find the acromion, and gently start to decompress the humeral head from the acromion. There we go. And now the humeral head's dropping. So I just took pressure off your supraspinatus tendon and your bicipital tendon. The last thing I'm going to do is basically reposition the scapula. Lots of trigger points back here, right? Levator, rhomboids. You can't dig on long lock muscles. So you have to put the muscles into a shortened position and activate them. So if I basically take your shoulder and bring the scapula back where it belongs to shorten your rhomboids and to shorten your levator scapula, then I put you on a mild stretch and I do spindle cell work like I did on the glutes earlier. Basically, muscle spindle cell work wakes up weak rhomboids, wakes up weak infraspinatus teres minor. It basically stimulates firing of the muscles of the back. And then the last thing I'm going to do is just check that subacromial space. Now we'll stand you up, please. So, giving credit to my colleagues, we let Kerry go first so he would know that he was really important. That was really important. He's one of my best friends in the industry, so we pick on each other. If you noticed, he dimmed the light so you wouldn't see the wrinkles of my face. So put your palms forward. Let's check Kerry's workout. Go ahead and abduct your shoulder. Just go up like that. Good inferior glide of the good movement of the clavicles. So I'm going to do one more thing. There's a capsular pattern. Lack of synovial fluid and hyaluronic acid. I go to the restriction and I create a little synovial fluid hyaluronic acid pump. I'll finish with just a little bit of relax your shoulder. There you go. Do you feel that drop right there? And now I want you to know you should have full abduction, but your anxiety is there, so let's do something cool. Remember John Travolta, do this. Go like that with your left arm. Come on. But move your hips. Focus on your hips. There you go. I distracted her brain from her shoulder. So now you can abduct your shoulder. And I'm going to turn it over to my colleague, Sean.
How's everybody doing this afternoon? Ooh, that was awful. I said, how is everybody doing this afternoon? That's much better. So we're going to do some fun stuff with the Thai massage and sports massage right now. So as my wonderful colleagues have gone and done some amazing work already, got everything stretched out, moved, got the capsule, I'm going to treat more of the fascial chain. So I'll get you to turn your back to everybody. Back. So what we're going to work on is the posterior fascial chain, all the way down in through the hamstrings and through the shoulder. Obviously the lat fibers play a lot of role, so the lat comes and then it starts on through here. So if the client has a lot of these capsular patterns, sometimes the fascial chain from the lat is going to affect that. So we're going to show you some fun techniques for that. So let's get you face down to start off with. So it's our left shoulder here. I like to be a little lazy, so I'm going to sit right here. I'm going to prop my foot up. Sometimes I like to grab the armrest. I can get further up into here. and I'm just going to kayak the shoulder. So anybody that likes to swim or does paddle boarding or need a little bit of kayaking. So I'm just going to get the shoulder joint, and I can play around with my foot, moving it back and forth underneath. Again, I'm trying to create movement, and then I can traction the shoulder. Okay, I can traction the shoulder out, move it around. Okay, I can get in here now using my elbow into the shoulder girdle, and same thing, still moving. Okay, I'm always creating movement within the joints. Okay, that's feeling okay so far? Yeah. Okay, and then I'm gonna come in here and I'm just gonna lean back, pull on the upper traps a little bit, get into the middle scalenes, and again, I'm just using my body. So I'm stretching out my own body, getting some own therapy as well as I'm doing this. Okay, then I can come in through here, and again, go and move. I don't have to stand. I can use my body. Okay, coming in, moving the shoulder. Okay, come in through the back, some rotation. Okay, get this abduction, internal external rotation moving better. Okay, come in through the forearm fascia, grabbing the wrist, pulling. I got some nice little cracks and pops happening in there because now we're getting the wrist moving. There we go. Remember, everything's connected from fingertips up to the head, so I want to create that mobility or that movement through there. Okay, mid-back, we're going to try to loosen this guy up now. Okay, T4 introduction for this nerve innervation. So we're just trying to move the T4 junction. Around this side. Again, to my body and stretch. Open the patient up. Getting a beautiful stretch. If I want, come support the head. Now I can move the head around. Have full movement here, just with my hand. And then I can stretch out. Scalenes, just rock the head, let it go. There we go. Scalenes are getting stretched out, getting full movement, full mobility here. Again, if I have a sheet, I would be pulling the whole sheet if my client is undressed. Those that are in my classes this weekend on Saturday, Sunday, I'll be showing those techniques, how to do that with the sheets. And I can actually get the leg in here, and I can get full body. And you see, she's safe. She's not going to fall off. I have her full weight. Okay? Again, I'm using my whole body to lean into this. Okay, let's get you on your back for me now. Same thing with the left shoulder again. I'm gonna put my foot here. Again, I'm gonna use the armrest. Again, just to pull up more, shorten the pec. Same thing. Do a little kayak. Get some movement going on. Joint, get the wrist. Stretching everything. Go. And I can actually come up. Traction up. Okay. Get a little bit high. This is very light. Not much pressure there. Not bad. Good part about these headrests from Carden, you can actually stand on the headrest. Do not do this with any other table. I personally designed this so you could actually put your weight on the table. Okay. Now you're gonna grab opposite foot, opposite hand. Okay, and just lean back. Come forward. Again, I'm getting the whole fascial chain. Left shoulder is connected to right hip. Right hip is connected to left knee, which is connected to right ankle. Cross, same thing. Using my body again, locking in. And then again, I can lean back and I can move. Now I'm stretching out the lower back. Contraction back again. Good, and if I get her to lift up her head for me, now I'm stretching out the spine. And relax the head. Good, and lift up the head again. And relax. Again, I'm getting the client to work with me doing this stretch. This is a beautiful stretch for the low back and the shoulder. Stretch over. I'm gonna get this last cheek. And this is just a soft tissue tool. These are called mile balls. Okay, they're just to loosen up things, get things moving. I can come in, massage with them. Okay, and then I'm just gonna give, now after all that treatment, we're gonna give it some love. And then, again, using my whole body. So I say we're moving like water. Use the body like it's water, and we move like water. Looking at it in both hands, moving around. Like a dance, I usually say. You're moving around. Come in here, and again, I'm gonna use my knees. Give a good stretch. It can be 2 knees, back. Okay, we're just stretching, moving around. Circular motions. Again, just creating mobility within the spine itself. Again, it's not much work on my hands. Okay, it's saving my body. Good, and then I can come in here. Nice stretching. And take this arm up, over, and stretch out the lat. Come through. Again, I'm leaning her against my body. She's not moving anywhere. Good. And stand up and see how that feels. How's that feel moving that around? You can see the mobility is quite different now. Because we got both the posterior fascial chain, lateral fascial chain, and a bit of that front fascial chain. Perfect, and I'll let Amanda take over. Thank you guys very much.